Hi dentist, how are you? This is Mohammed Musa from AFK Study Plan. Today we are going to do the third AFK weekly newsletter, which we are going to collect the question we posted in our community the whole week and give you the answer with the concept about it. If you don't do it before, I would really recommend you to join our community, see the question we are posting every day, see the answer and discussion about it, and at the weekend, Sunday, you will see this video which will recap the question, answers, and most importantly, the topics and the concept for this question, which I really aim for you to understand, not just the question and its answer. Okay, with that being said, let's dig deep into our newsletter. So, first question from Operative. And I know most dentists don't study this topic in depth because, like, it's not really important in the exam, but like, I would really recommend you to start doing this topic. Increasing the volume of fillers in a composite resin will cause all of the following except. This question has another trick, like this except word. If you miss it, because like when you're reading the question, okay, volume and fillers, a composite, so you think about physical properties, we think about statics, whoa, good. But then you miss this last word, except. And then when you read the option, you feel like you're a little overwhelmed. Increase hardness or strength, increase polymerization shrinkage, lower thermal expansion coefficient, increase of compression strength. So we know fillers introduced into the composite, which is the matrix, to give it more physical properties, to make it harder, to give it physical properties like to increase the wear resistance, to reduce the water solubility. So from this option, except increase hardness or strength, no, we know fillers are doing this, so we exclude this one. Increase polymerization shrinkage, no, it's other way. It's going to reduce. So except fit here, but let's read the other option. Lower thermal expansion coefficient, no, it's the other way, as a matrix is like very soluble, so it has high thermal of expansion, so it's going the other way. Increase of compression strength, yes. So here we have except word, which is little confusing. So when you read this one, increase polymerization shrinkage in the other way. But before we conclude the answer, let's first think about the composite and the composition of the composite. So composite is composite mean like composition, like two different material, which is the name here. So it's resin, which is the matrix, and then the fillers. The fillers use, as you see in this picture, to reinforce the matrix itself. Okay, so dental composites are composed of several main components. We'll speak about today only two. Organic matrix, which is the matrix form the bulk of the dental composite and is responsible for its physical and mechanical properties, consists of resin matrix typically composed of biphenyl A glyhydrate, methylphenidate, which is in short bis gamma, and then UDMA or other methyl methacrylate based monomers. The resin matrix provides the composite with its polymerizable and adhesive properties. So the matrix itself is the core of the composite. But as we said, this has poor physical properties, so we're introducing fillers are added to an organic matrix to enhance the composite strength, wear resistance, and aesthetic properties. They can be inorganic particles such as glass, quartz, or ceramic particles. The filler reinforce the composite and give it the ability to withstand chewing forces. They also provide the desired color and translucency to mimic natural teeth. Also, the composite has other components which is coupling agent because it's organic and inorganic. So we need a medium or something can bind here and here to make it a one composition at the end. Initiator to initiate the polymerization, and accelerator, and also pigments to mimic the tooth structure colors. But today we are going only to speak about the fillers. So the fillers has specific function. Fillers are added to composite material to enhance their mechanical properties and improve their strength. The filler reinforces the composite matrix, making it more resistant to wear and fracture. So the first one is reinforcement. Also, it increases the wear resistance. Filler help increase the wear resistance of dental composites, making them more durable when subjected to chewing forces and abrasive actions. Moreover, It increased the aesthetic properties. Fillers are responsible for mimicking the natural appearance of tooth. They provide opacity and color matching capabilities to dental composite, allowing them to blend seamlessly with the surrounding tooth structure, not like the amalgam fillings. And last thing, which is core polymerization control. Filler play a role in controlling the polymerization process of a dental composite. They help to regulate the shrinkage and curing characteristics, reducing the polymerization stress that can lead to marginal gap or tooth sensitivity. So it functions to reduce the polymerization, shrinkage, and stress relating from this. Also, the filler increase the handling properties, as filler can influence the viscosity and flowability of dental composite, making them easier to handle during placement, and also its radio opacity, which is extremely important. We don't want to introduce a filling that we cannot see in the X-ray. Some dental fillers contain radio opaque material such as barium, stratum, or zirconia, which make the composite visible in X-ray. The radio opacity enables dentists to monitor the restoration's integrity and diagnose any potential issues. So that was the whole concept about the fillers inside the composite. So with that being said, I think you can easily conclude the answer, which is as except here, except increased polymerization shrinkage. I hope that was clear for you. And please try to revisit this topic in your study regimen because it's important. And it's painful to lose question, which is easy. You just need to read it. That's it. Second question is from Lovely Pharma. A patient is taking atenolol, ozoxarpide, mononitrate, and diltiazem. The most likely diagnosis is, and this question is common. You might see it. And this question is mixing your knowledge about the cardiac condition and treatment, medication. It tests your knowledge how you know this medication is addressed which condition, this one is addressing which condition. So when you read it, you need to know the background of each cardiac condition, the pathophysiology of each condition, and how we are going to address it. So before we read the answers, let's speak about the condition and how we are going to treat it, and then you will see the answer very easy for you. So first cardiac condition we're going to speak about is the cardiovascular accident. Cardiovascular accident, by simple term, meaning a plaque inside the blood vessels leading to narrowing of the blood stream going through this blood vessel, leading to less blood flow to a specific area, which might be brain, might be the lung, might be the heart, might be any part in your body. And with this mechanism happening, it might lead to cardiovascular accident. So for this one, as you can see from the diagram here and from what I've said, how we are going to address this one. We're going to give our patient anticoagulant, which would be heparin or warfarin, and moreover, we're going to give them more stuff to address this problem, which usually will be antiplatelet agent like aspirin or clopidogrel. As you know, heparin is not commonly used for this one. We use heparin more for kidney dialysis, but like most frequently, you will see your patient over warfarin and aspirin, or sometimes it's aspirin, clopidogrel. So it mixes between anticoagulant and antiplatelet. So when you see a patient taking this profile of medication, so you would lean most commonly to be a history of cardiovascular accident. Second cardiac condition is angina. Angina happens due to less blood supply going to your heart itself. And when this happens, angina happens as a chest pain, discomfort, or tightness that occur when an area of the heart muscle does not receive enough blood oxygen. And this happens like, think about cardiac condition as a scenario. Patients start first with high blood pressure. This high blood pressure, meaning the narrowing of the blood vessels, meaning the less blood supply going to the various body organs, which include the heart. So this reflects strong as a clinical picture for your patient. He will give you this clinical picture. He will say, I have a chest pain, discomfort, tightness, because like your heart needs blood because this is the pump pumping the blood all over your body. So when you have a blocked artery, meaning less blood supply coming to your heart, means heart cannot deal with its function and cannot cope with the function he needs to do. So how we are going to address this condition? We're going to give our patient nitrate, which is like nitroglycerin in the basically leading to vasodilation. We're going to give him antiplatelet because as you see it's a plaque inside the arteries. We're going to give him statins which targeting the bad lipids inside your veins. We're going to give him beta blockers which end with olol or calcium channel blocker or ACE inhibitor or antiplatelet agent. So for this condition, stable angina, it has a wide spectrum of medication we're going to give to our patient. Why? Because it's a serious condition. If you don't treat stable angina, it will do as unstable angina, leading maybe to MI. So this condition is very serious. So we should introduce medication to deal with it. I'm not telling you patient will get all this medication. No, I'm giving here the profile. So nitroglycerin induce vasodilation, antiplatelet to block this one, and then we give him statin to deal with the bad lipid, a beta blocker or calcium channel blocker or ACE inhibitors to deal with this stuff, and sometimes you give your patient antiplatelet agent. So it's not for every patient. I'm just giving you the complete profile for every cardiac condition. And then we are going to myocardial infarction. And as you think about it now, if your patient has a condition which angina leading to unstable angina, means plaque build up more, which is atherosclerosis inside the blood vessels, leading to reduced blood flow, meaning this one you see in this picture, a less blood going to your heart. So your heart will have hard time trying to pump the blood, which will give you severe pain. So whatever we are going to deal as angina, we are going to add more. Maybe we are giving our patient anticoagulant. Sometimes we give him morphine or sedative. Morphine as a sedative mainly used during the acute MI. So we are not giving our patient morphine because he had history of MI, but now while he has MI attack, we're going to give him morphine. Why? Because it's extremely painful. So you need to relieve the pain for your patients. So whatever added here is the same as angina, but we add more anticoagulant. Okay, and then the last condition, which is congestive heart failure. This patient has history of angina, history of myocardial infarction, and his heart cannot pump, cannot do this part. So you see in your patient clinical picture, which is honestly it's very sad. You see he has swollen feet. You see this vein here is very prominent. He cannot breathe easily. It's very hard for your patient. So for this patient, we are going to give him diuretics. Why? Because when the heart cannot pump the blood will be stagnated. That's why you have this swollen feet. So you give him diuretics, trying to reduce the load over your heart. You're giving him some ARBs, some ACE inhibitors, beta blocker, and giving him digitalis. Digitalis is very narrow limited medication which has severe drug interaction with other medication. So when you give your patient this medication, you should pay attention to your epinephrine, local anesthesia, and other medication. Aldosterone antagonist and nitrate. Same aldosterone antagonist like act as a diuretics. And lastly is nitrate, nitroglycerin to make vasodilation here, leading to less blood flow to your heart. So congestive heart failure is a very serious condition. We are just trying to reduce the load over your heart and then getting rid of the fluid inside your body to make sure it's easier for your heart. So with that all being said, so let's read our option here. Our question, atenolol, which is beta blocker, mononitrate, which is nitroglycerin, and diltiazem, which is calcium channel blocker. So read our option. Atrial fibrillation and congestive heart failure. Congestive atrial fibrillation, maybe you give atenolol for your patient, but congestive heart failure, it will need more medication. You will need to give him at least, correct. And then congestive heart failure and myocardial infarction, no. As we said, this is a very severe condition. You need more medication than this. Cardiac ischemic disease, which is makes sense. We're giving him mononitrate, and hypertension because we're giving him atenolol and diltiazem as a calcium channel blocker. Last is myocardial infarction and ventricular arrhythmia. And arrhythmia has a different medication. We can discuss it later. It has different category to be addressed. But the bottom line here, myocardial infarction and congestive heart failure is a severe condition needing more medication about more than just calcium channel blocker and beta blocker. I hope that was clear. Just if you feel a little lost, you can pause the video, go back and read it, get the medication. I don't want just to tell you the answer. I would like you to understand the concept. And then when you have the concept inside your mind, when you have the knowledge about which medication is indicated for which condition, it will be super easy for you to conclude the answer for any question from the same topic. Okay, third question is from Perio. Chlorhexidine mouth rinse act on. Chlorhexidine mouth rinse is very famous. I think every dentist knows this one. And he's asking a question, which bacteria is working upon this one? Streptococcus mutans, lactobacilli, Streptococcus pyogen, and Candida albicans. I think from without you having any knowledge about chlorhexidine, you would exclude Candida albicans because Candida albicans is fungal. So it's not worth it to think about it. We're gonna speak about this. Before I give you the answer, let's speak about more about chlorhexidine. So chlorhexidine is a common antiseptic and antimicrobial agent. Is a chemical compound that belongs to a group called bisbiguanides. It's usually available as a liquid solution or gel, and it comes in different concentration and different uses. So this is the mouthwash. This is the liquid form. It has 2% and it's acting as antiseptic and antimicrobial agent. How does it work? Chlorhexidine work by disturbing and damaging the outer membranes of microorganisms like bacteria, fungi, and viruses. It does this by binding to their cell wall, interfering with their integrity and preventing their growth and reproduction. This action makes chlorhexidine an effective tool in fighting against oral infection. I think this picture mimic what penicillin is doing as antibacterial drug or antibiotic drugs. So it acts by the same mechanism. It disturbing the cell wall, leading to the bacteria to be boom, nothing. It diminish. It cannot be existing anymore. How we are going to use what's the indication to use chlorhexidine? Prevention of dental plaque and gingivitis. Like prevention here, I think is aggressive word, but like it's a very accurate wording because like chlorhexidine is very effective. It's bactericidal in specific concentration and bacteriostatic in less concentration than this one. But at 2%, it's bactericidal, so it will lead to less plaque inside patient mouth, which means no plaque, no problem, no gingivitis, no bleeding, everyone is happy. Chlorhexidine is commonly used as a mouthwash or oral rinse to control plaque buildups and prevent gingivitis, which is inflammation of the gum. It can inhibit the growth of bacteria in the mouth, reducing the risk of oral infection. So it's very important for you to know this. We are using this one as antibacterial and it acts as bactericidal. And we'll also use it as periodontal maintenance for our patient in case of periodontal disease where there is infection and inflammation of the gum and supporting structure of the teeth. Chlorhexidine may be used as part of a comprehensive treatment plan to control bacterial growth and promote healing. Like if your patient is a periodontitis patient and he's doing his part, brushing his teeth, using a floss, so you are giving him chlorhexidine as adjunctive to be added to his oral health habits to help him reduce the bacterial load inside his mouth. Chlorhexidine is effective against a wide range of bacteria, including both gram-positive and gram-negative species. Some of the bacteria that chlorhexidine is partially effective against include Streptococcus mutans. This bacterium is a major contributor to dental plaque formation and tooth decay. Chlorhexidine can inhibit its growth, helping to prevent cavities. Also, B. gingivalis, this bacteria is associated with periodontal disease and gum inflammation, can effectively reduce its number, aiding in the treatment of periodontal condition. And I have a question for you here. Which condition of gingivitis has this bacteria specifically in increased number? Please tell me you know the answer. And this, I will not read. It's very hard to read, but like it's AA. I think everyone know this one. This bacteria is another common cause of periodontal disease. Chlorhexidine can help control its growth and prevent further damage to gum and supporting structure of the teeth. Also, P. intermedia is associated with periodontal infection and can contribute to progression of gum disease. Chlorhexidine has been shown to be effective against P. intermedia. And this one is included in the same category about the gingivitis condition I speak about. I hope it's super easy now. I hope you can conclude it now. Fused spectrum nucleotum. This bacterium is commonly found in dental plaque and can contribute to gum disease. Chlorhexidine inhibits its growth and reduce its harmful effect on oral health. I think when you read the name now, you know why it's effective because it's targeting the major bacteria causing gingivitis, periodontitis, and pregnant gingivitis, it's very good. And why, like, some dentists we think, okay, so why we don't use it for every patient as a regular routine? Like, why instead of asking our patient to use Listerine, we are asking him to use Chlorhexidine. Chlorhexidine has two side effects. First, it will lead to discoloration outside your mouth. Second of all, think about it. If you give your patient long-term antibiotics, it will lead to candidal infection. Same here. If your patient is using Chlorhexidine as a daily base, every day, every day, every day, so the balance between bacteria and fungal inside the oral flora will be disturbed, leading to fungal infection. So that's why we are not using this Chlorhexidine for a long time. And honestly, if patient can use it for a long time, we are all gonna stay home. We will have no patient in our offices. You think? Yeah? Okay. Fourth question is from epidemiology. Which of the following provides the best information according to evidence-based dentistry? And then he giving you names of the study, case control, cohort study, randomized clinical trial, and systemic reviews. So for this topic, I did a complete lecture about it, about the ethics principles and the type of study and different type of study. I cannot just in 10 minutes tell you everything about it, so you can check the link here and watch the full lecture. I think it will be helpful for you, especially if you don't study this topic too much, which I know most of our dentists don't do. Okay, so in short, we can say this is the pyramid of epidemiology study. So it starts by background information, expert opinion, and then with case report or case series, meaning like I am a dentist in my office. I'm using specific material to treat like class 2 in kids. So I see this patient coming for me years after years, and he has a good oral hygiene. Restoration is good. There is no inflammation about the gum around this restoration. So I would say it's expert opinion. So I meet other dentists. They doing the same. So we are going to do case report or case series. So I'm going to make a presentation saying I use this material for this patient for a long time and it's good. Other dentists doing this, other dentists doing that. So it's a case series here. And this one is the least one we can depend upon it to get the evidence-based dentistry, because this is not nothing, it's not clinical trials, there is nothing has been done here. So when we introduce something which is case control studies, so we're speaking about different medication now, we're going to divide our patient to case and control, like case with a disease, control without the disease. So we have a study here. Or we're going to divide our patient based on the exposure to a risk factor. It will gonna be cohort here. Or we're going to try a new medication, which will be randomized clinical trials. And then we are going to conclude everything to go to systemic reviews. Systemic reviews is not a study by itself, it's filtered information. So systemic reviews, meaning like I did this one, other dentists did this one, and there is another researchers did these three types of research, and there is one other researchers getting all information here, which is unfiltered information, and he used his clinical criteria to say, okay, this study is good, this study go to garbage, and then he conclude a systemic review, which lead to meta-analysis, and this is the tip of our pyramid, leading to evidence-based dentistry, which lead to our textbook, which we have, and then we can use it in our patient. So that was in short. And the last is the systemic review, which is having the summary for all everything, for every study we have, gives you the summary. A meta-analysis is even more sophisticated, leading to, with a compiled analysis and use data to give you single summary result. So that was all for the study. I hope that was beneficial for you. If you need to know more about it, I would really recommend you to watch the video. It's good and condensed. So as we see here, the evidence-based dentistry is based upon systemic review and meta-analysis. The other three study has nothing to do with this topic. Last question from Perio. A patient has a pocket depth of 6 mm and attachment loss of 5.5 mm. What is the correct treatment in this case? And this question, when I posted in the community, there was some confusion about it, about the answer, and some dentists saying this is a different. So let's speak first about the probing depth and how we measure it, clinical attachment loss, and the rationale about perio treatment, and how we're going to think about the perio staging. And if you are doing this August exam, please pay attention to what I'm going to say now because it's extremely important. Okay, so first of all, this is the normal or the not normal, like most commonly you see in your patient, which means the gingival margin is at the cement to enamel junction with no recession. This is gingival margin, cement to enamel junction. For this condition, the probing depth, which is from gingival margin to the depth of the pocket, will be equal to clinical attachment loss, because the clinical attachment loss is from CEG to the depth of the pocket. So we have two different terms. Probing depth from the gingival margin to depth of the pocket, clinical attachment loss from cement to enamel junction to the depth of the pocket. In this condition, everything is good. Here comes the confusion. When the gingival margin is apical to cement to enamel junction, so you have a recession. So gingival margin is apical to cement to enamel junction, so you have a recession which is in a positive value. And the other way, when the gingival margin is coronal, you will have gingival recession which is in a negative value. So I hope this is clear for you, because this is the cornerstone. If you understand this one and you can visualize it, later it will be easier for you to understand the whole concept. So in the first scenario, pocket depth equal to clinical attachment loss. In the second scenario, the pocket depth plus the gingival recession leading to clinical attachment loss. So if I have a probing depth of 3, recession of 2, so the cal will be 3 plus 2 equal 5. And the other way around if it goes coronal. If it goes coronal, it may have a pocket depth of 7, and this from here till here is 4, so it will be 7 plus 4, leading to clinical attachment loss, which is 3. So that's why gingival recession here will have a negative number. When you put it, it will be easy for you to understand it and how to solve it. Okay? So here are the 3 scenarios. For scenario number C and B and A, and we speak about it, when we are going to make add up, or we are going to make it minus, or we are going to say it's the same. So in the same, we're going to say 4 plus 0 equal 4, or here minus, or here positive. So I think this is clear for you. If you don't get it, please pause the video and go back for this. And we have different type of pocket. First one is gingival pocket, as you see in A. What's the meaning of gingival pocket? There is no destruction of the supporting periodontal tissue. Here, the sulcus is here, depth of the pocket is still on the crown or near the crown, cement to enamel junction is not too far. And then we have suprabony pocket, where the base of the pocket is coronal to the level of the underlying bone, and the bone loss is horizontal. We see this most commonly in our patient with periodontitis leading to horizontal bone loss generalized in his mouth. So probing depth increased 5, but still the pocket, the depth of the pocket, the deeper part of our pocket still suprabony. And here patient, when he has vertical type of bone loss, you will see the depth of the pocket is even apical to the crest of the bone. Okay, this is clear also. How we are going to heal our patient, how we are going to treat our patient. So we have a competition here. We have infection here. We need to get rid of this infection, and we're going to say how we're going to get rid of this. And then we have different type of soft tissue want to replace the infected part. So we have cementum. Cementum is not growing, so I'll not speak about this one. PDL, also little capacity of growing. Bone has no capacity of growing. And then we have our rabbits, which is connective tissue and epithelium. Connective tissue and epithelium has the highest reproduction and turnover rate between this type of tissue. So as you can see here, we have two types of healing: repair and regeneration. For repair, which is this one, long junction epithelium, and there is a most common type of healing, meaning the connective tissue at the rabbit one will go very fast here to cover all this area, and the epithelium will go very deep here to cover the part exposed to the root surface, which means we don't have PDL here. So for this patient, you will have increased probing depth, but no bleeding, because this area is healed now with no problem. Or we may have connective tissue to overcome the epithelium and run toward the root, and then it will go some root resorption. Or we might have cementum, and this is very rare, cementum to overcome everything and try to cover the root itself, so it leads to ankylosing because there is no PDL, so there will be a direct contact between the bone and the cementum with no PDL, which is ankylosing. And the last thing which we usually aim to with is the new connective tissue attachment, which has been like before. We'd have cementum, connective tissue, epithelium in the upper side, and BDL. And this one cannot be done without surgeries. We need to intervene with membrane and bone graft to reach to this one. So the conclusion here, the most common type of repair is the long junction epithelium, and regeneration cannot be done by itself. You need to intervene surgically to treat your patient. So here's the concept, here what we are aiming to, and now I'm going to give you the rationale and the timeline how we treat our patient. So phase 1 therapy is a critical aspect of periodontal treatment. Data from clinical research indicate that long-term success of periodontal surgical treatment is dependent on maintaining the plaque or biofilm control results achieved with phase 1 therapy. So they say not every patient coming to you are going to do surgery. We need first to do phase 1. Why? Because they saw like the level of maintaining the plaque is the most important or critical criteria, meaning leading to success or failure of periodontal surgery. In fact, patients who do not have adequate plaque or biofilm control will continue to lose attachment regardless of what surgical procedure are performed. Based on the knowledge that microbial plaque or biofilm is a major etiological agent in gingival inflammation, one specific aim of phase 1 therapy for every patient is effective daily plaque or biofilm removal at home. I hope this is clear before we go deeper. So what we are going to do? First, we are going to do management of all contributing local factor is required in phase 1 therapy. Meaning, patient education, oral hygiene instruction, you need to see your patient brushing his teeth, you need to check how he's brushing, how he uses the floss, make sure he's doing this at home. Complete removal of supragingival calculus, which you're gonna do in your office. And then you are going to correction or replacement of polyphenic restoration, because this one is area of accumulation because it's rough, leading to stagnation of food, so you need to remove this one. And then restoration or temporalization of carious lesion, meaning if patient has a class 2 cavity which is deep, you need to fill it, make a good restoration to make this area less stagnation, less chances of stagnation of food. Orthodontic tooth movement, because alignment of teeth is critical here. Treatment of boot impaction area, meaning like if your patient have impacted lower 8, you take it out. Treatment of occlusal trauma, extraction of hopeless teeth, and possible use of antimicrobial agent. So all this need to be done in phase 1. So when I'm telling you what's done in phase 1, everything here is done in phase 1. Okay? After phase 1, after you give him education, how to control his plaque, how it's important, and it's in at first appointment, and when he's coming to you in second appointment, you do removal of calculus accomplished using scalar, curettage, ultrasonic instrument, and then evidence suggests that the treatment result from chronic periodontitis are similar for all instruments, which could be hand instrument or other mechanical instrument such as ultrasonic scalar. So you cannot say, okay, the ultrasonic is more effective than hand instrument. No, evidence said it's equally effective. In addition to calculus and the plaque or biofilm removal, cementum exposed to the pocket environment should be removed. So when I'm asking you which tissue we are going to remove in the first visit of supragingival plaque or calculus removal, so we are going to remove plaque, we are going to remove cementum, which is infected. We are not going to remove whole cementum around the root surface. No, we are going to just remove the cementum which is infected, which means like how I know this is infected cementum. The cementum near to the calculus, we are going to remove it. Why? Because the cementum will be porous here. So even if you remove the calculus and leave the cementum, it has limited capacity of healing. So it will be rough area, leading to more calculus and plaque stagnation later. At one time, it was thought that the removal of all cementum was necessary to attain a smooth, glossy, hard surface, which is not anymore because this will lead to sensitivity. The rationale was that cementum become necrotic from penetration of endotoxin from the microbial biofilm and would interfere with healing. Current studies have indicated that endotoxin do not penetrate into cementum as deeply as once believed, and complete removal of cementum may not always be necessary, but removal of plaque or biofilm and calculus is absolutely necessary. So we remove plaque, calculus, and infected cementum, and that's it for this phase. And then we are going to do recontouring, defective restoration, and crown correction of restorative defective, because this, as we said, lead to more stagnation of food, or complete replacement of filling restoration may be necessary. And then management of carious lesion. If patient has class 2 deep cavity, it need to be replaced and cleaned and give him a good restoration to reduce the plaque accumulation and food accumulation here. And here come the interesting part: tissue reevaluation. After scanning, group planning, and other phase 1 procedure, the periodontal tissue require approximately 4 weeks to heal. So when I'm asking you what is the correct frequency for you to recall your patient to check his progress of oral hygiene, minimum 4 weeks, saying 4 weeks to 6 weeks. So if we say about the maximum will be 8 weeks. More than 8 weeks, if your patient, you did phase 1 and he came to you after 8 weeks, so it will be a little tricky for you to know everything. So you need to re-evaluate again here. But the rationale here is the minimum is 4 weeks. Why? This time allows the connective tissue to heal and accurate probe depth can be measured. Patient will also have the opportunity to improve their home care skill to reduce gingival inflammation and adapt new habits, will ensure the success of treatment. As we said before, plaque is a criminal here. At the re-evaluation appointment, periodontal tissue are probed and all related anatomical conditions are carefully evaluated to determine whether further treatment, including periodontal surgery, is needed. So now we're going to the real deal. Additional improvement from periodontal surgical procedure can be expected only if phase 1 therapy results in gingival tissue that are free of overt inflammation and the patient has adopted effective daily plaque and biofilm control procedure. I explained it now in a 3 different ways to conclude for you this. When our patient has poor plaque routine control, it will make nothing. It will be just waste of time and money for everyone to do a perio surgery for him. And we said the minimum is 4 weeks. I will give you more evidence why 4 weeks. Scaling and root planning therapy have been studied extensively to evaluate their effect on periodontal disease. Many studies have indicated that this treatment is both effective and reliable. Studies ranging from 1 month to 2 years in length demonstrated up to 80% reduction in bleeding on probing and mean probing depth reduction of 2 or 3. So a patient coming with 6, 7, first to be done is non-surgical treatment. Other studies demonstrated that the percentage of periodontal bucket of 4 mm or deeper was reduced by more than 50% in many studies, up to 80%. In addition, deeper probing depth present the dentist was greatly increased in instrumentation challenges due to the complexity of the root anatomy and difficulty accessing the root surface. Some study reported that residual calculus remained on 44% of the surface in deeper pocket. So here come the problem. Meaning, when you're doing for your patient, he will come back to you with a reduction in the probing depth. But some sites will have less reduction. It will stay more. It will stay 6, it will stay 7, it will stay 5 or 5.5. It will stay deeper. Why? Because there is local factor here. Because of the root morphology here. Because of something here need to be corrected. So here come to use your plate to do the surgical intervention. Healing of gingival epithelium consists of formation of long junction epithelium rather than new connective tissue attachment to the root surface. As we speak before, this long junction epithelium occur about 1 week after therapy. Numbers are important. Gradual reduction in the inflammatory cell population, cervical fluid flow, and repair of connective tissue result in decreased clinical signs of inflammation, including less redness and swelling. 1 or 2 millimeter of precision is often apparent as a result of tissue shrinkage. As you clean it, it's not a big deal. You are trying to give him a hygienic medium here. Connective tissue fiber are disturbed and lyased by the disease process and also by the inflammatory reaction to the treatment. These tissue require 4 or more weeks to reorganize and heal, and in many cases may require several weeks for complete healing. So the minimum is 4 weeks up to 8 weeks, as we said. Transient root sensitivity frequently accompanies the healing process. As we said, we remove the necrotic symptom. The extent of sensitivity can be diminished with gold plaque and biofilm removal, but this may take several weeks to months to be relieved. It is fortunate that many periodontal involvement cases do not require any further therapy beyond phase 1 therapy. However, advanced or complicated cases benefit from a specialized care. Here is the cutoff. This scientist said Lang demonstrated that surgical treatment in deep pockets, those more than 6 mm, gained 0.6 mm more probing depth reduction and 0.2 mm more clinical attachment gain than did deep pocket treated with scaling and root planning alone. So 6 and up, we should use our plate. This study also confirmed that in pocket of 4 to 6 mm probing depths, scaling and root planning resulted in 0.4 mm more attachment gain than surgical procedure, and shallow pocket of 1 to 3 mm had 0.5 less attachment compared with surgical result. So this two paragraph meaning surgical intervention for these numbers leading to more. Surgical intervention for this number leading to same or maybe less. Why less? Because you are interfering with the integrity of soft tissue, which we said before, every scaling and root planning will lead to minimal shrinkage of soft tissue. So when you intervene in these small numbers, damaging soft tissue, you are violating the structure and integrity of soft tissue, leading to less favorable outcome. The concept of critical probing depth of 5.4 mm has been advanced to assist in making the demonstration to proceed to surgical intervention. This is the measurement above which therapy will result in clinical attachment gain and below which it will result in clinical attachment loss. A similar 5 mm standard has been commonly used as a guideline for identifying candidates for surgical referral based on the understanding that the typical root length is about 13 mm and the crest of alveolar bone is at level approximately 2 mm apical to the bottom of the pocket. Let's stop here and explain it again. So you remember the picture we told you about the suprabony, infrabony pocket? They concluded that the length of the root in average is 13 mm. So when you have more than 5.4, this number, this means and adding to it 2 mm, as this is the normal level of the alveolar bone to the cement-to-damage junction. So in this number, 2 added by 5.4, so you have 7.4. So when there is a 5 mm of clinical attachment loss, the crest of bone is about 7 mm apical to cement-to-damage junction, and therefore only about half of the bony support for the tooth remains. So in this condition, cannot be treated by non-surgical intervention. In this condition, surgical intervention is the goal, and you need to do surgery to intervene with this one and solve it. I meant to explain everything about this condition and how we're going to go through it, because when I give the answer for this question, people were confused how to do it, how to think about it. So you have 3 factors to think about this one. Pocket depth is useless if you don't have this number, attachment loss. If you don't have attachment loss, he will give you the relation between cement-to-damage junction and gingival margin, which you can conclude the attachment loss. So when you have increased probing depth, you are not jumping to be periodontitis. You should have attachment loss. And when you have this rationale, and when you have this number, so the treatment here will be surgical intervention. I know some dentists would say, okay, for the question, he didn't mention the level of plaque control, which phase and which treatment and which stuff and which scenario. And this is a very bad idea to think about question. When you have a question, just go simply with the wording. Avoid overthinking. Question is saying pocket depth 6 mm and giving you information to confirm there's attachment loss and giving you the number, exact number 5.5. So he's giving you numbers according to the study has been done. So for you to go for surgical intervention, you don't say, okay, so this patient, I don't know, maybe he need more hygiene measurement, maybe he need comprehensive treatment to remove his defective restoration, and maybe we need to go scaling and root planning, or maybe he has vertical root fracture, so let's do extraction, or maybe this patient has endoperioral lesion, so let's do scaling and root canal. No, do not overthink it. It's as simple as mentioned in the references. This number needs surgical intervention, so you should do surgical intervention. I hope that was clear. I know this part was heavy, but I meant it to be covering every step in the treatment for periodontal condition and how we are going to follow up, the rationale, the numbers, how we think about it. I hope that was clear for you. Have a lovely weekend and see you next week.